Hello, my name is Swathi Eluri, and I am currently a gastroenterology fellow at the University of North Carolina at Chapel Hill. On behalf of my co-authors and myself, I would like to talk to you about our study titled "The Extreme Narrow Caliber Esophagus is a Treatment-Resistant Sub-Phenotype of Eosinophilic Esophagitis." Eosinophilic esophagitis, or EOE, is a chronic immune-mediated disease characterized by esophageal dysfunction and eosinophilic infiltration. Two commonly recognized phenotypes in EOE are inflammatory and fibrostenotic. Those with an inflammatory phenotype tend to have symptoms of nausea and abdominal pain with exudates, furrows, and edema on endoscopy. Patients with a fibrostenotic phenotype typically present with dysphagia and tend to have rings and strictures on exam. In addition, about 10% of EOE patients have extreme narrowing that extends the entire length of the esophagus, which differs from strictures which are focal. This diffuse narrowing has been labeled a narrow caliber or small caliber esophagus. These are endoscopic images of the narrow caliber esophagus characterized by a diffuse decrease in the esophageal caliber. In addition to significant narrowing, we see rings, edema, and exudates. While the narrow caliber esophagus has been recognized as a distinct manifestation of EOE, there are no studies to date that have described this group in detail. Therefore, one of the reasons that we conducted this study is to characterize EOE patients with a narrow caliber esophagus, determine associated risk factors, and assess treatment response to topical steroids. Based on our experience at our center, we hypothesized that EOE patients with a narrow caliber esophagus were more likely to be adults at the time of diagnosis with longer symptom duration, have more treatment-resistant disease, and likely represented a sub-phenotype of EOE. We performed a retrospective study at UNC from 2001 to 2014. All participants had an incident diagnosis of EOE per consensus guidelines, including non-response to a PPI trial. Narrow caliber esophagus was defined as the need to use a neonatal endoscope with a diameter less than 6 millimeters to traverse the esophagus due to inability to pass an adult upper endoscope secondary to narrowing. Cases that allowed passage of an adult scope despite a decrease in esophageal luminal diameter were referred to as regular caliber for the purposes of our study. Esophageal strictures could be present in either group. We compared clinical, endoscopic, and histologic findings between the narrow caliber and regular caliber cases. We also studied response to steroid treatment, which at our institution was an 8-week course of swallowed budesonide or fluticasone. Out of 513 participants, 9% had an extreme narrow caliber esophagus. Narrow caliber patients were older, with only 13% being children. They also had longer symptom duration, higher rates of dysphagia, and food impaction. Endoscopically, everyone in the narrow caliber group needed dilation, with a third needing repeat dilation within 8 weeks. In contrast, only 26% of the regular caliber group needed dilation. Histologically, there was no difference in the maximum number of eosinophils per high power field between the narrow and regular caliber groups. In addition, we found that the narrow caliber esophagus patients were more treatment resistant and had significantly decreased odds of improvement of symptoms, endoscopic findings, and histology following topical steroid treatment. The next natural question we had was whether the narrow caliber esophagus represented a more severe and end-stage manifestation of the fibrostenotic phenotype or a treatment-resistant variant. In order to answer this question, we performed a sub-analysis comparing treatment response between the narrow caliber cases and those with strictures but had a regular caliber esophagus. Similar to the primary analysis, we found that the narrow caliber group had worse treatment response compared to those with strictures, arguing that the narrow caliber is likely a separate sub-phenotype of EOE. Reasons for the poor steroid response, which was not explained by either steroid dose or type in our data, are unclear and will need to be further investigated in the future. In conclusion, in this study, we characterized a new sub-phenotype of EOE, the extreme narrow caliber esophagus, defined as requiring a neonatal endoscope to traverse the esophagus. We found that this group was more treatment-resistant to steroids. It may be a group that needs more aggressive dilation, a higher steroid dose, a longer steroid treatment course, or other therapies, but this needs further study. Therefore, recognizing this group of EoE patients can have important prognostic implications in terms of determining treatment decisions and predicting treatment response. Thank you for your time and opportunity to share our work with you.